Good morning, ladies and gentlemen. I'm Dr. Tung from IVFMD Medical Hospital from Vietnam. So today I want to present our finding from our case control study evaluating the serum AMS level as a diagnostic tool for polycystic ovarian syndrome among the Vietnamese women. This study was performed by the MD-PSSG group using data from IVFMD, and I have no financial relationship or other conflicts of interest to declare. Currently, the diagnosis of PCOS is primarily based on the Rotterdam criteria, which require the presence of at least two of the following features, including the biochemical or clinical sign of hyperandrogenism, ovulation disorder, and ultrasound findings of polycystic ovarian morphologies, which has been recently defined as the presence of more than 20 andro follicles in each ovary or an ovary volume greater than 10 milliliters. But however, the Rotterdam 2018 and 2023 consensus also were considered about the limitations of the PCOM criterions for diagnosis. So what are the limitations? First, the andro follicle count is heavily depends on the operator skill and the equipment. And this will not recommend it for PCOS women not recommended for the PCOS diagnosis in adolescents and those with less than 8 years post-menopause. And some women will feel uncomfortable and refuse to have a transvaginal ultrasound. And to do ultrasound via transabdominal or transrectal will affect the accuracies. On the other hand, the AMS is secreted by the anti-mullerian hormones, is secreted by the granulosa cell from pre-antral and antral follicle, and it contributes significantly to the PCOS pathogenesis, and there are established correlations between the AMS and the antral follicle count. This reinforces the role of AMS as an alternative criterion for diagnosis of this syndrome. But however, significant heterogeneity exists across different studies reporting the AMS cutoff for diagnosing these syndromes. This may be because of the difference between different ethnicities or the high intra and inter-assay variability, especially in those using the manual AMS kit testing. And the clinical factors such as the BMI and age might confound the result. So that's why we think that we consider whether we can evaluate the diagnostic role of AMS in PCOS while accounting for the confounders such as the ethnicity, the assays methods, and the clinical factor including the BMI and age. And that's what also our primary objectives. The secondary objectives including we want to describe the age-related AMS trend in women with PCOS and compare to the control counterpart. And we want to identify the significant factor associated with the serum AMS level in women with PCOS also. So this is the inclusion and the exclusion criteria. We include all the Vietnamese women aged from 18 to 45, and they have a serum AMS testing using the automatic elastic system, which is approved by the FDA. And for the PCOS group, we only include the patient who is diagnosed using the Rotterdam criteria and have a metabolic and endocrine data available. The exclusion criteria including those with uterine or ovary abnormalities and or those with the sex chromosome abnormalities or a history of previous radiation, chemotherapy, or surgeries. And in our center, we have a work protocol for PCOS women. So if they come on the beginning of the cycle, we have the clinical evaluations and the laboratory testing. For the clinical evaluations, we measure the general and the anthropometric measurement, including the age, BMI, or blood pressures, the fat mass, or lean body mass. And we also do the examinations and found the PCOS-related clinical features. For laboratory evaluations, we evaluate the level of the reproductive hormone, the metabolic parameter, including the thyroid function test. And this is the study workflow. We screened it on the medical records from 2019 to 2024, and finally, we have 1,200 PCOS patients and more than 7,000 non-PCOS control. And after matching with age and BMI as covariate, finally, we have 1,162 patients for each group for further analysis. This is the characteristic of the clinical PCOS manifestation and phenotyping. So the PCOS type A or type D account for more than 90% of the study populations, and 95.5 patients has PCOM. And look at the BMI distribution by the WHO ASEAN classification. You can see more than 60% of the patients have a low BMI or in normal range. That means the lean PCOS phenotype account for nearly 60% of the Vietnamese PCOS population. And before we match the data, we observe differences in age and BMI between the two groups. And after the control, the baseline characteristics become similar. Then we perform the ROC analysis, analyzing the Jordan index. We report an area under the curve of more than 88%, and with an AMS cutoff at 5.055 nanogram per milliliter. We have a sensitivity of 85% and 75% of specificity. We also compare, we construct the curve of the AMS level across age. So the control exhibit a clear decline of AMS level with age. But however, the PCOS women show no meaningful correlation between the age and the AMS level. And the differences in the slope change between the two curves reach significant level. We performed the univariate linear regressions analysis first, and then factor with a p-value less than 0.2, and the factor that had been proved previously that correlate with AMS, and we include them all in the final multivariate analysis. The result demonstrates that only the total testosterone concentrations significantly and positively correlates with the serum AMS level. Interestingly, the free androgen index or the hyperandrogenism clinical manifestations do not correlate with the AMS level. So when we compare our results with the results from other studies in the same regions, our cutoff value demonstrate equivalent diagnostic performance, but however, the strength of our study lies in the assessment of potential clinical confounders. And this is another unpublished secondary analysis using the data from one of our previous study. That study performed in the same region with data from 12 centers across Asia and Pacific. And when we published the paper, we didn't evaluate the change of the AMS across age in the PCOS group. And I performed this secondary analysis to compare and to confirm our finding again. And in this data, we also observe the same trend of AMS across age when comparing the PCOS and non-PCOS women. The AMS were also well preserved in women less than 38 years old, but the decreased trend started at those about 38 years old. We didn't observe this one in our study or in our data, maybe because of the number of the women with advanced age in our data is limited compared to this data. So in this study, we have more than 27 women of 40 or more, but in Vietnamese population, we only have around 6 patients. And the similar finding of the two data show that the AMS is more preserved across age, especially in young women with PCOS. And the age-related AMS pattern differ between the two groups, and it's become a challenge with the idea that there is AMS cutoff visible, universal, and optimal for PCOS diagnosis. So in conclusion, after we adjust for confounder, where we found the optimal cutoff for PCOS diagnosis in the Vietnamese woman at 5.05 nanogram per milliliter with a sensitivity of 25% and specificity of 75%. And the serum AMS level remains well preserved across age in PCOS women, particularly in those less than 38 years old. And the biochemical hypoandrogenism show a stronger correlation with AMS level than its clinical manifestations. The limitation of this study is that we have no data on the metabolic or endocrine disorder for the control group, so that we can compare the two groups. And the diagnostic cutoff for PCOS in this study were derived specifically from the Vietnamese population only. And the study population primarily consists of young women with PCOS only, so that maybe we cannot have a comprehensive view of the AMS change across in these populations. I want to express my appreciation to my colleagues and the international supervisor of the study group for their invaluable support in completing the project. Thank you very much for listening.